Hello, and welcome to this section of the webinar series, CVI for Medical Professionals. We will be discussing diagnostic criteria for CVI. Currently, there is no single test to diagnose CVI. In this section, we will use the current working definition of CVI developed by the Trans-NIH CVI Working Group to discuss the approach to diagnosing CVI. Please note that this is a working definition which is in progress and may undergo minor changes in the coming months. Just to give you a preview, the 5 elements of the working definition are shown here. Number 1, CVI is a spectrum of visual impairment caused by an underlying structural and/or functional brain abnormality which impacts development of visual function and processing. Number 2, the visual function in CVI is greater than expected by any comorbid ocular conditions. Number 3, the visual abnormalities in CVI may manifest as lower or higher order afferent visual deficits with or without efferent or oculomotor disturbances, leading to characteristic behaviors. Number 4, while CVI may be comorbid with other neurodevelopmental disorders, CVI is not primarily a disorder of language, learning, or social communication. And number 5, although the neurologic insult resulting in CVI occurs in the developing brain, it may not be diagnosed until adulthood. All individuals with a diagnosis of CVI may require long-term support throughout their lifespan. As we go through this session, we'll go through each of these elements one by one to break it down so you understand what diagnostic criteria can be used to meet this definition.
Hello, I'm Margaret Reynolds from Washington University in St. Louis, and I'm going to start our discussion on the CVI diagnostic criteria. I'm going to start talking about the first diagnostic criteria, which is CVI should be a spectrum of visual impairment caused by an underlying structural and/or functional brain abnormality, which impacts development of visual function and processing. And we're going to break this down kind of piecemeal. So first, the spectrum of visual impairment in CVI. We're going to really delve into this later about the visual characteristics. So I'm going to focus on the other parts. So next, we'll focus on it's a spectrum of visual impairment caused by an underlying structural and/or functional brain abnormality. As you can see here, this is the visual pathway. So any part of the visual pathway in the brain can be affected in CVI. Next, we're going to discuss the causes of CVI, and I'm going to show you structural correlates of these most common causes of CVI. So first, hypoxic ischemic encephalopathy. You can see these are MRI images of a young child affected by HIE. Next, prematurity with periventricular leukomalacia. You can see these corresponding MRI images. Trauma is another common cause of CVI. This is specifically an example of non-accidental trauma. Hydrocephalus can be a cause of CVI, and this is a corresponding MRI image. Infections can cause CVI. This is an MRI showing meningoencephalitis. Toxic metabolic and genetic orders can also cause CVI. This specific example is metachromatic leukodystrophy. Structural brain abnormalities can cause CVI, and you can see this example of schizencephaly. And then finally, CVI can be caused by seizures or in utero drug exposure. The most common cause of structural changes leading to CVI includes ischemia in preterm and term infants. So specifically talking about preterm infants, they can often present with periventricular leukomalacia, or PVL, as the most common cause of brain injury. And this schematic on the side shows the cause of this. It's associated with hemorrhagic necrosis in the periventricular white matter, just dorsal and lateral to the external angle of the lateral ventricles. The main factors associated with PVL are underdeveloped vasculature of the surrounding white matter, as well as impairment of regulation of the cerebral blood flow. And both of these things can predispose the white matter to ischemic injury. Crucially, as the tracks of the optic radiations and higher order visual functions travel within the periventricular white matter, PVL is often associated with impaired visual processing. And you can kind of see some of these manifestations in these images, which are the same images that I showed earlier. Next, perinatal hypoxic ischemic encephalopathy occurs in term infants, and you can kind of compare the differences here in these mechanisms of injury, but the sequelae of HIE is determined by the severity and duration of the hypoxic event, as well as gestational age. It's related to vascular perfusion, watershed zones. Closer to term, infants have higher metabolic demand, and the more commonly damaged areas include deep gray matter, the hippocampus, the brainstem, and the thalamus. And so you can see this is an MRI of a patient with HIE. So another kind of way to look at the structural causes of CVI. So these are white matter reconstructions of the three main pathways involved in visual processing, namely the superior longitudinal fasciculus, the inferior longitudinal fasciculus, and the inferior frontal occipital fasciculus. And you can see that there's just an obvious difference between the sighted control. This is an individual who has ocular blindness, and then the individual here with CVI. Another way to kind of represent some of the underlying brain changes in individuals with CVI. So this demonstrates whole brain network connectivity. And you can see here that whole brain network connectivity, when examined in a sighted control in a patient who's ocularly blind, it's pretty similar. However, when you compare this with the individual with CVI, there's just markedly reduced whole brain connectivity in individuals with CVI. And then the next part of this diagnostic criteria, CVI impacts development of visual function and processing. To kind of briefly touch on this, depending, if you kind of think back of those examples and the imaging, so depending on the location and the extent of damage, children with CVI can present with just a myriad of visual deficits, including decreased visual acuity, impaired visual field, and they can also have significant impairments in visual processing and attention, which can really impact their learning, development, and independence. So here on the side here, you can see these visual developmental milestones. And if you kind of look at these different things, these can be impacted in CVI. And then kind of another point here is that the visual impairment in children with CVI does not always correspond to structural changes. So investigators have attempted to image these patients using functional neural imaging, including PET scans, single photon emission, computerized tomography, and functional MRI. PET scans in 8 sedated children with CVI showed decreased glucose metabolism in both the primary and secondary visual cortex. And PET activity did not correlate with visual acuity by forced preferential looking or VEP. And then next, this is a scalp map plot showing EEG data obtained from viewing the virtual toy box task. So this is the control here. You can see the occipital parietal signal was robust in this control, and it peaked here between 350 and 375 milliseconds, versus this is the individual with CVI, and it shows just overall reduction in signal, with the peak being at a similar time as the control. So to kind of, again, go back to this diagnostic criteria, the definition, a spectrum of visual impairment caused by an underlying structural and or functional brain anomaly, abnormality, which impacts development of visual function. So the definition and then the corresponding diagnostic criteria. So patients with CVI have visual dysfunction in association with the neurologic condition affecting the developing brain. The next criteria that we'll focus on here is that the visual dysfunction in CVI is greater than expected by any comorbid ocular conditions. And so just to kind of break this down by using an example, this is a image, a color fundus photo of a young child who has congenital toxoplasmosis. The vision in this eye is light perception, which obviously we wouldn't expect given the macular scar here. But then if you look at the corresponding MRI, there's also CNS findings implicating CVI in this individual's decreased vision. And then this is another example of a color fundus photo showing just this temporal optic nerve pallor. And this patient had a similarly appearing left eye. And this person had bilateral light perception, visual acuity, again, out of proportion to this exam. And this individual was also diagnosed with CVI. So just to kind of think about deficits associated with CVI patients, so focusing on this specific study by Ditta et al., these individuals often have comorbid neuro and ophthalmological deficits. There's in about half, about 20% had only ophthalmological deficits, and then 30% had only neurological deficits. So just something to keep in mind. And then similarly, individuals with CVI can have concomitant causes of visual impairment, including uncorrected refractive error, cataract, nystagmus, retinopathy of prematurity, and optic nerve atrophy. These have all been reported in individuals with CVI. And the same group showed just the percentage of ophthalmological deficits associated with CVI in this patient population, of fair percentage with strabismus. Ocular motor apraxia was common, and we'll draw attention to the fact that optic nerve atrophy was also in about 10% of patients. So again, focusing on the definition and the corresponding diagnostic criteria. So the definition, the visual dysfunction in CVI is greater than expected by any comorbid ocular conditions. And the diagnostic criteria, the severity of visual dysfunction is out of proportion to any ocular pathology.
I'm Melinda Chang. I'm a pediatric neuro-ophthalmologist at Children's Hospital Los Angeles and the University of Southern California, and I'll be continuing the discussion of diagnostic criteria for CVI. So I'll be talking about the third element of the CVI working definition. The visual abnormalities in CVI may manifest as lower or higher order afferent visual deficits with or without efferent or oculomotor disturbances, leading to characteristic behaviors. CVI can affect lower order visual function, higher order visual processing, and ocular motility. It's also associated with characteristic behaviors. As mentioned in the definition, patients with CVI may have either lower or higher order visual deficits, or both. Although oculomotor abnormalities are common in patients with CVI, the presence of these oculomotor deficits alone, without lower or higher order visual afferent visual abnormalities, is not considered CVI. We'll talk more specifically about each of these categories. The first group of characteristics affected in CVI are those that involve lower order visual function. In general, lower order characteristics include features that are processed earlier in the visual pathway at or before the level of the primary visual cortex. In patients with CVI, lower order visual characteristics are generally affected when there is damage to the optic radiations or the striate cortex. The first and most commonly measured lower order visual characteristic that may be affected in CVI is visual acuity. In CVI, visual acuity may range from 20/20 to no light perception. Most patients evaluated by pediatric ophthalmologists have decreased visual acuity, which can be quite severe. Many patients with CVI are unable to participate in optotype visual acuity testing. One quick way to measure visual acuity in these patients in the clinic is by grading visual behavior using a 6-level scale. This 6-level visual behavior scale was first proposed by Bill Good and colleagues, and it has since been adapted by several authors to describe the level of visual acuity in patients with CVI. In this scale, the first 4 levels represent vision that is worse than the definition of legal blindness, or 2200. Visual acuity is graded based on the ability of the patient to fixate and follow objects of various sizes and at various distances. Although this is convenient to use clinically, it is not granular enough to detect small changes in visual acuity, which is important especially in research studies. Another method to assess visual acuity in patients with CVI is using sweep VEP. With sweep VEP, visual acuity can be quantified because we record the electrical responses in the visual cortex in response to visual stimuli presented at various frequencies, usually by using a grading or a checkerboard pattern. In this seminal study by Dr. Good, we see that the visual acuity of children with CVI, shown in red circles, is decreased compared to age-matched controls, shown as blue squares, in almost every case. Preferential looking using teller acuity cards can also be used to assess visual acuity in children with CVI. In a recent study, Dr. Hidari and colleagues at Boston Children's Hospital compared visual acuity assessment by sweep VEP and teller acuity cards. In this graph, sweep VEP is on the y-axis and teller acuity is on the x-axis. The diagonal line indicates perfect correlation between the two measurements. As you can see, nearly all of the dots are above the diagonal line, indicating that sweep VEP nearly always overestimated visual acuity compared to teller acuity cards. It's possible, however, that teller acuity actually underestimated visual acuity. Patients with CVI may have difficulty performing teller acuity due to limitations in visual attention, visual field defects, or ocular motor abnormalities. Another aspect of acuity that may be affected in CVI is vernier acuity. This refers to the ability to detect misalignment or positional offsets, as shown here. One study using VEP showed that vernier acuity may be affected to a greater degree in children with CVI than grading acuity. Contrast sensitivity is another lower-order visual function that may be affected in CVI. Sweep VEP can be used to measure contrast sensitivity when the stimulus sweeps through different levels of contrast instead of different frequencies of gratings. In this study, patients with CVI were found to have significantly worse contrast sensitivity than controls. Interestingly, the subgroup of patients with CVI due to hypoxia, shown in the open circles, had better contrast sensitivity than the CVI group as a whole. However, this subgroup still had worse contrast sensitivity than age-matched controls. Color is another lower-order visual characteristic that has been studied in children with CVI. CVI patients generally respond well to brightly colored objects and toys, and they may have a specific color preference. In this preferential-looking study, children with CVI spent more time looking at static colored bars compared to static gray bars. Color perception is thought to be relatively spared in CVI, and this may be due to multiple areas of the visual system being involved in color processing. Of course, damage to the optic radiations and primary occipital cortex leads to visual field defects, which vary depending on the location of injury. In this case study, a patient was found to have bilateral inferior visual field defects. The structural MRI scan of the CVI patient, shown on the bottom, demonstrated periventricular leukomalacia, which occurred in the setting of prematurity. Diffusion imaging, which assesses the white matter tracts, showed that the patient with CVI had bilateral defects in the superior bank of the optic radiations, which corresponds to the inferior visual field defects. Next, we'll move on to higher order visual processing deficits that are observed in patients with CVI. These broadly refer to challenges that are localized to visual processing that occurs after the primary visual cortex, in the visual association areas including the dorsal and ventral streams. These higher order visual deficits in patients with CVI were described by Dr. Ditta as cortical visual dysfunction in 1996. Most experts now consider these to be features of CVI. Characteristic higher order deficits in CVI include difficulties with recognition, which are referred to as various agnosias, including prosopagnosia, or the inability to recognize faces, challenges with depth perception, also called astereocognosis, difficulty with orientation, which has been termed topographic agnosia, difficulties with movement perception, or akinetopsia, and challenges with simultaneous perception, which is called simultanagnosia, and can translate to difficulties with distinguishing targets in a visually complex environment. Difficulty with face recognition has been described in patients with CVI for some time and has recently been quantified in this elegant study. Individuals with CVI and controls were asked to perform two tasks, a face task and a glass pattern task. In the face task, the participants were required to match a blurred face to one of the four options. The level of blurriness in this face was variable. In the glass pattern task, participants were asked to identify the circular pattern created by coherently placed dots among the four choices. The level of coherence of the dots was varied. The authors found that individuals with CVI, shown in blue, performed worse than controls, shown in orange, on the face task, as indicated by a higher blur threshold. However, the performance was not different on the glass pattern task. Also, response time was slower and the proportion correct was lower than controls when CVI participants performed the face task, whereas there was no difference between the groups on the glass pattern task. This indicates that the patients with CVI had a specific deficit in face recognition, which was not generalizable to the recognition task involving coherent dots. Patients with CVI have also been found to have more difficulty with recognizing abstract images than realistic images. In this study, participants were shown images of the same entity, in this case a cat, with varying degrees of realism, from abstract black and white drawings to color photographs. Individuals with CVI and controls were then asked to identify the images. The graph indicates that patients with CVI, shown in gray, performed worse than controls in terms of success rate of identification. The performance was progressively worse as the degree of realism decreased, with the lowest recognition rate for the abstract black and white drawings. The patients with CVI actually performed the same as controls on the color photographs. Practically, this suggests that children with CVI should be given materials with realistic images, especially when these are used for communication, as with AAC devices. Another common higher order visual processing deficit in children with CVI is difficulty with visual complexity, which has been attributed to simultagnosia. This video shows an example of a child with CVI who is able to easily see a string of gold beads on a plain background. He looks at the beads and grabs them and puts them in his mouth. However, when he tries to find the gold beads on this visually complex background, he cannot do so visually, so he tries to find them using touch. When this fails, he gets frustrated and he pushes the tray away. Problems with visual complexity often translate to difficulties with visual search. This is an eye tracking study where participants performed two tasks in a virtual reality setting. In the first task, participants were asked to find a toy in a toy box, and the difficulty varied depending on the number of colored distractors. In the second task, the participants were asked to find a person, called the principal, in a school hallway. The task difficulty depended on the number of people in the hallway. In both tasks, individuals with CVI had lower success rates and longer reaction times. Their pattern of visual search was also different. Based on eye tracking, they had higher rates of gaze error and larger search areas. These results quantify difficulties with visual search experienced by individuals with CVI, which can translate to real-life challenges with finding a clothing item in a closet or a specific food on a crowded dinner table. The issue of motion processing in CVI is complex. In many patients, motion processing appears to be relatively spared, and children with CVI tend to prefer looking at moving objects compared to still objects. Motion may be required to attract their attention. Some patients with CVI have even been described to have blind sight, where there appears to be total blindness except that they have intact motion perception. Conversely, patients with CVI can also have a selective deficit in motion processing. Specifically, they may have problems with complex motion, such as global motion perception. This can be tested in a laboratory using a random dot kinematogram. In this stimulus, some dots are moving randomly and some dots are moving coherently in a certain direction. The threshold at which the participant can identify the direction of coherent dots is indicative of a global motion processing deficit. In this study, patients with CVI had a significantly higher motion coherence threshold compared to controls, indicating the global motion processing deficit. In real-life situations, this may translate into difficulties with detecting the direction of motion of cars on a street, for example. Patients with CVI often have abnormalities of ocular motility. However, as mentioned previously, oculomotor deficits alone, without any deficits of lower or higher order visual perception, are not sufficient to be considered CVI. For example, oculomotor apraxia is not a type of CVI. Many oculomotor problems are found in children with CVI. Strabismus is present in a high proportion of patients. When they have cerebral palsy, especially dyskinetic cerebral palsy, they may have paroxysmal deviations that change from esotropic to exotropic. Nystagmus can be seen in patients with CVI, especially if they have an associated ocular abnormality such as optic atrophy. Oculomotor apraxia, or difficulty generating saccades, has been described also in patients with CVI. In these cases, it can be challenging for the clinician to determine what the patient sees based on visual behavior, especially if the child does not yet have sufficient head control for head thrusting. Absent vestibulo-ocular reflex has been described by Dr. Brodsky. Increased saccadic latency or longer time to generate a response to a visual stimulus is also very characteristic in patients with CVI and may lead people to think their vision is worse than it actually is. Fixation instability or absent or asymmetric smooth pursuit have both been described in patients with CVI, and these can be quantified using eye tracking methods. Patients with CVI may also have decreased or disorganized visual exploration of the environment. Many of these oculomotor abnormalities were noted by Dr. Jacobson and colleagues in 2002. In their cohort of 56 patients with CVI following perinatal hypoxia, approximately 80% had at least one of these ocular motility disorders. Using eye tracking, Glenn Prusky and colleagues demonstrated asymmetry of pursuits in children with brain injury. These radial charts indicate the direction and amplitude of pursuits during an eye tracking task. In many cases, the pursuits were markedly asymmetric, and this improved over time with recovery from brain injury. At our eye tracking lab at CHLA, we also noted significant oculomotor abnormalities in children with CVI. Compared to controls, CVI patients had longer fixation latency, longer fixation duration, and lower fixation frequency. In other words, they took more time to make a fixation, and when they did so, they tended to persist in fixating at a particular spot instead of making a saccade to a new location. Saccades were also significantly different in children with CVI. CVI patients had longer saccade latency, lower saccade frequency, and also made more saccades away from the visual stimulus or off the screen. This is indicative of difficulties with visual attention in children with CVI. Next, we will discuss behavioral characteristics of CVI in children. In patients with CVI, visual function tends to fluctuate based on factors related to the environment as well as the child's current state. Vision is often better in familiar and less crowded environments. It's also, when the child is sick or tired, vision tends to be worse. Children with CVI often turn away when looking at something, which has been called an eccentric gaze preference. The reason for this is unclear, but could relate to the use of remaining visual field in patients who have visual field defects. Children with CVI are also often observed to prefer looking at lights, including overhead lights or screens, but paradoxically, some patients with CVI have been noted to exhibit photophobia. A possible reason for this apparent photophobia was investigated in this VEP study. Here, the authors measured grading acuity in high and low luminance conditions in children with CVI and controls. In controls, acuity was better in high luminance conditions. However, in CVI patients, acuity is worse under high luminance. This suggests that some patients with CVI may avoid brightly lit environments because their visual acuity is actually better in dimmer conditions. However, this behavioral characteristic is not universal in children with CVI, and as mentioned previously, some patients with CVI actually prefer to stare at lights. So we've talked in this section about how the visual abnormalities in CVI may manifest as lower or higher order afferent visual deficits with or without oculomotor disturbances, leading to characteristic behaviors. This leads us to the corresponding diagnostic criterion for CVI. Patients with CVI must have a measurable abnormality of visual function, which may involve visual acuity, contrast sensitivity, motion detection, visual search, recognition of faces or objects, or other visual deficits that have yet to be described.
Hi, I'm Ditta. I'm a pediatric neuro-ophthalmologist at the University of Tennessee Health Science Center and Le Bonheur Children's Hospital. My talk will focus on two important elements in the working diagnostic criteria for CVI that were discussed at the Trans-NIH Cerebral Visual Impairment Workshop, Roadmap to Consensus and Building Awareness, which took place in November of 2023. And so first I will talk about the concept of comorbid conditions that are commonly seen in patients with CVI, particularly neurodevelopmental disorders, and we'll discuss the impact of these. Then I'll shift gears to discuss the concept that although the neurologic insult resulting in CVI occurs in the developing brain, some individuals may not be recognized as having this condition until they are adults. So here we will focus on the longitudinal support that these patients need over the course of their lifetime. What are the roles of the pediatric ophthalmologist, helping us give our patients lifelong support? So let's start by talking about CVI characteristics. And children with CVI frequently exhibit characteristic visual behaviors that differ from those with ocular causes of vision impairment. And these characteristics can be quite profound, and they might seem out of proportion to what we would expect to see, especially in the setting of an otherwise normal ophthalmological clinical examination. These characteristics affect the activities and routines of a child throughout the day, and they can result in the child exhibiting delays in various areas across gross and fine motor skills, mobility, socialization, and group activities. And importantly, these difficulties that children have with vision can vary based on the time of day or change depending on the environment in which they are in. We also know that children with CVI often have complex medical issues and various forms of developmental delay. And I believe this really creates challenges for the pediatric ophthalmologist when assessing a child with CVI, because so many of these patients cannot be tested with our objective tests that we are classically taught in our training. It can certainly be challenging to capture the breadth of deficits in visual function exhibited by these children, and many of us really do feel limited in our capacity to comment at all. And this really is quite problematic because it can lead to delays in diagnosis as well as referral to services. And realistically, these patients are vulnerable. They are at risk for long-term morbidity, and they need the most help. And so we need to try to understand the whole child. And the earlier that we can do this and make a diagnosis of CVI, the sooner we can implement a team-based approach to care. So as Dr. Chang mentioned, the two-stream hypothesis of visual processing is now a widely accepted concept for how our brain processes vision. And there are two highly integrated visual pathways, both with cortical and subcortical neuroconnectivity. So when visual stimuli reach a functioning occipital lobe, we experience our primary sensory functions in vision: clarity of picture, color processing, recognition of contrast, and assessment of the visual field. From here, visual information is processed in other places and in different ways. The dorsal stream processes motion and evaluation of the visual scene. It gives appropriate attention to the objects of interest and creates a 3D map of our external world, facilitating visually guided movements with precision and appropriate navigation. We also have a ventral stream processing, which allows us to make sense of what we are seeing. It's like a visual library, allowing us to consciously recognize what we see. And these neuroanatomical structures and pathways are highly interconnected and integrated with the subcortical neurons that allow us to perceive what we know as vision and appropriately cognitively to respond to it. And it's the lack of this normal integration that can result in many of the stereotype behaviors of CVI. Processing in the brain is not only complex, but it is also vitally important and time sensitive. As we learn how our brain processes vision, we continue to find evidence underlining the crucial role of vision in our cognitive and social development. So our early sensory experiences contribute to our brain development. And from birth, vision guides our movement and it helps us integrate motor control. It facilitates social and emotional interactions. And because vision precedes action, it promotes voluntary decisions to experience and thus begin to understand the world in which we live. As Dr. Reynolds shows, the sensitive period of binocular vision development occurs early in life and continues throughout childhood. This diagram from the Aravind Eye Care System is quite nice, and I like to keep it in my clinic as a resource to families because it demonstrates simply the visual and developmental milestones in a way that a parent can understand. It also alerts the parent that if a child's trajectory is not appropriately on track, then they should seek help. And for many parents, especially first-time parents of newborns, this really doesn't resonate with them until too much time has passed. Newborns instinctively orient towards faces, which is an important first step in establishing and maintaining relationships. And without appropriate visual processing, development of these skills is impaired, causing young children to be delayed in meeting their milestones, or it may actually lead to inappropriate development across multiple domains. So an infant who is at 3 to 4 months of age, who has not developed good visual attention or the ability to fixate, needs further evaluation and referral to early intervention services. And this is really considered a developmental emergency, that lack of eye contact that impairs communication and emotional connections. And we, as the pediatric ophthalmologist, should recognize this. So I've heard many parents say, well, my child was diagnosed with CVI, but it was diagnosed very late. And this gets back to the question, why is it that CVI can be so challenging to diagnose? In part, this is due to the fact that that disturbances of visual processing have been closely associated with a range of neurodevelopmental conditions, like autism spectrum disorder, which has been reported to have a prevalence of up to 25% in the visually impaired population, and various intellectual and learning disabilities. In autism spectrum disorder, children have persistent deficits in social communication and interaction across multiple contexts, as well as restricted, repetitive patterns of behavior, interests, and activities. When we talk about intellectual disorders and learning disabilities, one in particular that discussed often within ophthalmology is dyslexia. When children struggle to learn to read, one of the first suggestions from the pediatrician and teachers is to get an eye exam. And while certainly a child who cannot see will have trouble reading, dyslexia is a specific learning disability that is neurobiological in origin, characterized by difficulties with accurate and or fluent word recognition, poor spelling, and decoding abilities, often resulting from a deficit in a phonological component of language. These conditions are independent diagnoses, yet it can be very challenging to make a distinction between them. This is because autism spectrum disorder and learning disorders both have been associated with anomalies of visual and perceptual function. And we know that CVI impacts the early cognitive development, adaptive skills, and as well as the fact of social relationships, which can clearly impact a child's quality of life. Additionally, delays in visual processing have been shown to possibly contribute to manifestations of autistic-like traits. So here's an example: object permanence. The concept of understanding that whether or not an object can be sensed has no effect on whether or not it continues to exist. And this is a cognitive developmental milestone acquired through vision. And it's this learned concept that really facilitates our early understanding of causality, as well as the motivation to approach others and interact with other people and objects. So you can see that while these conditions are essentially interdependent diagnoses, they are interrelated and there's marked potential for overlap. However, it's important that we recognize that CVI is not primarily a disorder of language, learning, or social communication. And knowing this, there are still questions that we need to answer. Like, when a child has overlap in these diagnoses, we need to understand what is primary and what are the drivers for visual impairment, and how do we quantify them? For children with very poor visual function, many tests used to assess for autism and learning disorders rely on visual capacities. And for children with high functioning CVI, what resources do we need to have to decipher these diagnoses? So we're definitely faced with unique challenges as we explore these complex relationships. Even though there's much work to be done to help us understand this condition, we as pediatric ophthalmologists have an opportunity to improve the quality of life in these children. And we have an important role, and there are very specific things that we can do. First, we can identify these children as having CVI, recognizing that they are at risk, and making a diagnosis when appropriate. When we make the diagnosis in the clinical note, it really does carry weight, and that alone can make a huge difference in the lives of these children and families. We need to treat ocular conditions that we can treat. Importantly, we need to document medical necessity for vision services and also try to make specific recommendations for the patient. Even if you cannot adequately provide objective information about a patient's vision, or you're unsure about what a child can see, to what capacity, or what to capacity they use their vision for function, it's still quite helpful to state that and state that you're concerned that this child may be at risk for having vision impairment and this could affect their development. We need to make specific recommendations. Additionally, we need to make prompt referrals for vision, early intervention services, and sometimes back to the pediatrician and/or for appropriate evaluations. In school-age children, we refer the parent back to the school with the clinical note in hand so that they can begin making accommodations in the classroom. And remember that we were trying to take care of the whole child. Finally, we must provide information and guidance to families about not only diagnosis, but what are the next steps that might be next to help this child. The APOS Pediatric Low Vision Rehabilitation Committee continues to put together resource sheets for families, which are easily accessible. Remember that education is empowerment for these caregivers. And finally, we need to communicate with the care team and with the multidisciplinary services. They truly value what we say. So we really do have an important opportunity to improve the quality of life of children with CVI. So to summarize, while CVI may be comorbid with other neurodevelopmental disorders, CVI is not primarily a disorder of language, learning, or communication. Visual abnormalities are not explainable by other neurodevelopmental diagnoses, such as autism spectrum disorder or dyslexia. So as I segue from this topic to the next, I'd like to present a case. So this is a 17-year-old female with diplegic cerebral palsy referred by the rehabilitation specialist from the family because they're concerned about a teen's vision. This child was a former 29-week ex-preemie. They had ROP, they had amblyopia, they were under amblyopia therapy, and had a mild refractive error, but in general, they had good vision. The patient had been followed by the ophthalmologist throughout childhood, but was never diagnosed with CVI because they had good vision. However, the parent reported that they were getting good rates in school, but the child had to work very hard to achieve these. The parents and the patient felt that vision often interfered with the ability to access educational materials. They were talking about needing more time to complete the work than other students. They had difficulty copying from the board, described difficulty with complexity and the array, especially with math problems, geometry, and word problems, and then had difficulty finding objects on busy backgrounds. Here's the clinical examination, and you can see that the patient sees quite well in low prescription glasses, and other than having optic atrophy, had a fairly unremarkable eye exam. So given the clinical examination findings and the complaint of the parent, the question really should be asked, does this child have CVI? Does the visual dysfunction seem greater than expected by any of the comorbid ocular conditions? And the answer here is yes. While this child was known to have an abnormal MRI from infancy, it was never further explored. And delving a little bit deeper, now this child is a teenager and finally getting a CVI screening questionnaire, and it became apparent that she was experiencing and demonstrating many of the CVI characteristics. And so it was really on the brink of adulthood that the diagnosis of CVI was made, even though the neurologic insult resulting in CVI happened in utero in the developing brain. And I think this case is really great at demonstrating the point quite clearly that you can still have CVI even if you have really good acuity. Also, I think it emphasizes that it can be hard to make a diagnosis, not only in children with very low functioning vision, but also in patients with normal or to near normal visual function. And we'll see patients at all ends of the spectrum, but there may still be barriers preventing us from moving forward with making a diagnosis. So in these situations, we really need to listen to the parent, listen to the patient, and make sure that we at least have a suspicion of CVI so that we can consider the appropriate next steps and referrals to best help the patient. The last thing I'd like to discuss is transition of care. And as the last case emphasized, CVI really expands beyond the early years. It's a lifelong condition. And again, although the neurologic insult resulting in CVI occurs in the developing brain, individuals require long-term support extending into adolescence and the teenage years and into adulthood so we can be equipped to care for these patients beyond infancy. While there is an expectation that a child's vision will improve over time, children with CVI do have persistent deficits in visual acuity and visual function. And reported characteristics associated with a lack of improvement in vision include an older age at presentation, a diagnosis of hypoxic ischemic encephalopathy, seizure disorder, and the need for multiple anti-epileptic drugs. As well as having CP and the presence of an abnormal fundus examination. However, again, we really are just at the beginning of understanding all the etiologies of CVI and their impact on vision. These children often develop coping and compensatory skills so that their CVI characteristics change over time. And it's really our job to see how they profoundly impact vision, not only in infancy, but over time. So as we follow these patients, we need to be able to better understand their vision, their capabilities, their struggles, and how their needs change over time. Clinical guidelines recommend that primary caregivers provide guidance and support to ensure a planned transition from pediatric to adult care for adolescents beginning about 12 years of age. And so we should have a plan in place for these patients as they begin to reach the appropriate ages for transition of care and understand what support they need going forward. It's important that we recognize that most adolescents, however, don't receive the recommended healthcare transition planning. And what's particularly concerning is that adolescents diagnosed with mental disorders, behavioral, and other developmental disorders, who account for approximately 20% of the adolescents in the US, is really the group that's most vulnerable and are already at an increased risk for long-term morbidity and mortality. Yet compared to children without developmental delays, they are 25% less likely to receive transition care planning, which they so desperately need. So the reality is that there are large gaps in our healthcare system, especially during these periods of transition. And specific to patients with vision impairments, add to this the fact that we also know that vision services are quite region dependent. And so this creates problems. So again, we as the pediatric ophthalmologists need to consider the benefits of timely healthcare transition planning and how it might mitigate adverse outcomes for our patients, particularly those with special needs who have limited access to resources. Again, we need to understand these transitions and understanding that at that time, these are when these patients are at most risk and most vulnerable. Patients and family members may be anxious about the potential loss of resources. These young adults have maybe losing their biggest advocates, their parents, or teachers for the visually impaired who have worked with them over the years. Really, it's their entire support system that may be about to change. So it's important that we keep this in mind and we make sure that we're the ones continuing care into adulthood. Remember, adults with CVI need support, including access to multidisciplinary care teams. Finally, children with CVI grow up. So what strategies do we have to improve the transition of care services? First, it's never too early to start. And it's important to establish care with an adult provider before stopping care as we, the pediatric ophthalmologist, are caring for them. We don't want to create gaps in care, and direct communication is always best. We should discuss age-appropriate topics and consider how CVI will impact certain milestones. This might include the transition from middle school to high school, driving, moving from high school to college, and then the evolution towards independent living. Along with this, we need to create an inventory of needs. So what will this young adult need as an adult? At the transition points now and going forward. Remember, not all children with CVI are the same. So some patients have pervasive deficits, whereas CVI for others is an invisible disease. And so it looks different for each patient. It's important that we remember to include everyone in the conversation. It's the child that soon is going to be an adult living with this condition, not the parent. So if their voice can be heard, we want to take those into consideration as they gain their independence and knowing what's important to them living with CVI. Everyone really wants to be heard. And finally, we need to be aware of the local, regional, and national organizations and agencies that can help these patients. This includes educational institutions, as well as occupational agencies. And of note, we need to document medical necessity for resources. And this needs to be reflected both for CVI for vocation and activities of daily living. The more we document, the better access these patients have to care. So in closing, improving access to comprehensive and coordinated programs and services, as well as increasing provider training concerning adolescents' unique mental health conditions and physical care needs could help increase the number of adolescents benefiting from successful healthcare transitions. So although the neurologic insult resulting in CVI occurs in the developing brain, it may not be diagnosed until adulthood. All individuals with a diagnosis of CVI may need long-term support throughout their lifespan. And adults 18 years and older, ages greater than 18 or older does not exclude a diagnosis of CVI. Thank you.
In summary, the 5 elements of a CVI working definition correspond to the 5 diagnostic criteria that we discussed in this session. Number 1, patients with CVI must have visual dysfunction in association with a neurologic condition affecting the developing brain. Number 2, the severity of visual dysfunction is out of proportion to any ocular pathology. Number 3, a measurable abnormality of visual function, such as visual acuity, contrast sensitivity, motion detection, visual search, recognition of faces or objects, is present. Number 4, visual abnormalities are not explainable by other neurodevelopmental diagnoses such as autism spectrum disorder or dyslexia. And finally, age greater than 18 years does not exclude a diagnosis of CVI. This concludes our webinar on diagnostic criteria for CVI. Thank you.